Marcia Carr is an NCA that I've known for a number of years. She's been involved, I think, since pretty much the beginning. She's from the Vancouver area, where she works as a clinical nurse specialist for Fraser Health, Delta White Rock, and the Medical Clinical Network. She's on faculty at UBC and Victoria School of Nursing. She works with Simon Fraser Research Centre with older people. Is a clinical assistant at McMaster as well. So go ahead, Marcia. Thanks.
Thanks so much, Grace. And this is kind of an ongoing saga, this continence management protocol for acute care. Because those of you that were here that were at the CNCA in 2014, I spoke about the development of it. Well, this is how we've progressed in 2 years. So change is slow. So the objectives that I'm going to try and cover today are to provide a background and rationale for the need to develop this protocol, provide how it was developed, describe the pilots and revisions, provide how it affected improved patient care and outcomes, and then finally provide a forum to discuss what you may be doing at your locations. The main driver behind this, to be perfectly honest, is that CIHI puts out certain data, and it's called nurse-sensitive adverse events. Well, we didn't like that, so we've changed it to care-sensitive adverse events. But included in that is UTIs, and they track the data. Fraser Health, where I work, the data was awful in terms of the prevalence of UTIs. So that was one thing. The other thing that they track is pressure ulcers. But in looking at pressure ulcers, how many were actually incontinence associated dermatitises that ended up in terms of skin breakdown? And tomorrow, Dorothy is going to really enlighten us more on that. But this is just my little piece, my little contribution to it. So we needed to deal with hospital-acquired UTIs, catheter-associated UTIs, as well as pressure ulcers. But ultimately, it came down to continence status. The background, as I said, was to the need to decrease and preferably prevent UTIs, and all effort was initially focused on catheter-associated. So we have lots of protocols around catheter-associated UTIs. Get them out. Don't put them in, but get them out within 24 to 48 hours. And we only treat symptomatic UTIs. No even testing. Smelly, cloudy urine doesn't mean that somebody has a UTI. So there was a massive amount of education that had to be done around this because as nurses, of course, we have really good noses and really good eyes. So automatically we would be proactive in sending CNS urines off and then getting our orders afterwards. Well, often it would come back and they would be borderline positive. And so as a result, the docs would say, okay, we're going to treat it. Then we ended up with C. diff, which is a nightmare, as everybody knows. And then on top of that, they would then get the UTI again, because now they've got this terrible diarrhea. So the discoveries. If HODI are now not primarily caused from indwelling catheters, then what else is contributing to UTIs? Well, everybody here can pretty much guess what it is. And so what we found out, and is this a big surprise to anybody, that they were being put in briefs. If you, under this dye is a lot of gray, and the wrinkles too. So if I arrived in Emerge, what happens? If you look like you're old, you automatically are assumed that you're incontinent. So they would put on briefs, and away we went. And in terms of toileting, it was pretty much not happening. It was, and even that whole issue about the call bell, because they have good urge, and that is fabulous, but yet It was, can you just hold on? And not going to happen. So what is the answer? Put on the largest Hoover Dam that you can find. And it didn't matter whether you were 97 pounds soaking wet or 300 pounds. It was, I'm going to put on the largest one. So if there was a bariatric one available at any time, that's what would go on. But it was always the extra large. And so it's because the notion was the bigger, the better, right? But toileting was just not there. And even with our previously continent adults, they weren't necessarily being asked whether or not they had a problem before they came in. So for those of you that are aware in BC, the Ministry of Health actually has a mandate around what we must do, and it's called 48-6. Within 48 hours after admission into hospital, you have to address 6 major items that cause rapid decline in older adults. And one of them is around bowel and bladder. The other one is around functional mobility, so can they actually get to the toilet? All of these are red flags that are to help us prevent rapid decline when, in point of fact, we can get them better and we can get them home. In terms of nights as well, there was the whole notion, and there were studies previously done, that older adults needed to sleep all night. So many products were developed to absorb so that you didn't disturb anybody overnight. Well, in the morning, what did you have? Everything was wet and overflowing. So didn't matter how big the product was, didn't matter how absorbent it was, because nobody was checking to even see. So I'm not trying to bash in any way nurses and practice. This was what they thought was the best thing to do. So what we decided to do was to develop and implement a comprehensive best practice protocol that looked at the contributing factors and helped the staff decide the most appropriate care for each patient. And often what happens is that if you force function and you take away certain things, and that's forcing function, they do adapt a little bit faster. And we're going to review and provide limited products, and that's the forcing of the function. And to prevent iatrogenic causes that ultimately increase length of stay, increase the possibility that they will get a nosocomial infection and everything else. And then we were going to demonstrate that patient outcomes are improved with decreased UTIs, decreased incontinence-associated dermatitises, and decreased length of stay. I don't know about your health authorities or where you're working, but access and flow is major, because we've always got backup in our emergencies, ranging from anywhere on the average from about 12 waiting for admission to 90 at some hospitals, and they're just overflowing. I mean, they're out the doors. As you may have heard, that at one of our hospitals, we actually converted Tim Hortons to a patient care area because it was around to merge. But we're not proud of that. So we of course, we started with looking at the evidence again and built upon that. And so a lot of this you already know because this is what we practice. So functional UI, FI increases when the patient is automatically placed into a brief and actually put to bed. Warm occlusive environment traps heat, enzymes, and moisture promoting microbial growth, and healthy stratum corneum has a low pH. Soaked briefs and reusable underpants trap heat, perspiration, and humidity, so we had to look at this, and then prolonged skin contact with moisture. Additionally, the whole issue about fecal enzymes and the ability to change somebody as soon as they have a bowel movement, and especially when they have C. diff, there was a whole other issue that produced a lot more IAD. Higher skin pH is an important factor in the development of IAD, and increased microbial counts on the skin can also attribute to ascending bacteria causing HOTI, which is hospital-acquired UTIs. And we really were trying to emphasize that as well. And 33% of hospitalized older adults have fecal incontinence. So the development of the protocol. So we had an interdisciplinary team actually develop this. It was frontline direct care RNs, myself as the CNS, the clinical nurse educators, WOCNs, OT-PT, professional practice leaders, and physicians were there, but they were on the periphery. The most important thing, though, was that we had our product specialists from our supply department. So we in BC have a collective that where all products are decided upon, and then the province implements them. And so we had to have them on board in order to know what we currently had in our supply chain and what we could then change. Managers and directors were there as well, ad hoc, but they were there so that we can keep them in the operational loop in terms of budget. A copy of the protocol, by the way, can be acquired from the conference information if you want it. We utilize the evidence to formulate the protocol that includes toileting as the #1 intervention. And everywhere where we actually implemented and tested at Burnaby Hospital was toilet, toilet, toilet. Toilet is the first action. Do not put on a brief. Take them to the toilet, please, and respond. If they are unable to get to the toilet, then we have urinals. The number of men that are put into product with urinary incontinence, and it's only because they can't get to a toilet fast enough. We looked at all of those types of things, female urinals. So toilet, toilet, toilet. And our commodes at the bedside went up considerably as well. We developed a lot of decision-making algorithms, and in order to build these algorithms, we honestly used Frontline to help us do this. Because if you do not have the direct care provider on board and working with you, you will get absolutely nowhere. They must be able to have a voice, and they must see through that their feedback is actually listened to. So this protocol has actually taken, since the last time I spoke to you about the protocol, we've been testing it for 2 years because it's needed changing due to the type of things that we wanted to make sure that we had buy-in and change over time. So this is what the algorithm looked like. It's very, very hard to see. And even with my being right here and being able to look at it directly, it is busy. But what it is that we looked at both fecal and urinary. And so you have to make and follow through the algorithm and answer the questions as you move down. The next one was the actual selection. What you would use, if you had to use product, then what are you going to use for collection? What are you going to use for containment? And what was really, really interesting when we were working with staff is that they never really divided out containment and collection as something being different. They didn't look at collection, they only thought about containment, which was also a piece of learning for us. So it was raising awareness to shift the brief culture, and that was done initially slowly, and then finally we literally took them out. And there were some of us assigned to actually go unit to unit and look in any spot that the stash may have been in order to take out briefs. And and there was good reason behind this, because if we had even one brief, and we started on the surgical unit, which was really interesting, because it was probably the unit where we could get buy-in quickly because their patients turn over faster than medicine. So we went in and we took everything out. What we learned at that time was that they have very good connections with other units and with families in terms of even product being brought in. So again, raising awareness, talking about what needs to be done, and moving forward from there. But always, always providing the ability for feedback. So this is what we saw. This is what we wanted to prevent. So we also developed an incontinence dermatitis algorithm, and we didn't develop it, it was actually Dorothy that developed it, and we've been using this. So we trialed many, many products, and again, we brought it down to 3 products. The toughest part of this whole exercise was our supply chain. Was being able to work with our supply chain about what we needed in terms of what eventually is now on those units. It was also, this is how we got buy-in, so we started with the surgical units and then went forward from there. And the other thing is that we started to see much more use of condom drainage. The toileting was great because we were seeing less deconditioning, which contributed to increased functional mobility, so they could actually now toilet themselves and get onto the commodes or get to the toilet. The outcomes, there was an increase in the need to toilet, to see toileting and not relying on product so much. The next thing is the IAD and accompanying pressure ulcers were reduced from 62% incidence to 4%. That's a huge, huge reduction. Data on HODI incidence decreasing. This is variable, though, during the high capacity times as well, as when there is a higher use of casual staff. We did see some variations, but it was reduced from 68% to 3 in 4 months. So this has had a huge, huge impact. There was a decrease in patients with functional incontinence. There was reduced nursing workloads as it takes 5 minutes to toilet a patient versus 12 minutes to cleanse the skin post-incontinent episodes. Only 2 patients required the special ordering of briefs, and they were kept at the bedside with their names on it and it was only as they were not to be moved off. And there was a close eye kept on it by the staff as well. So this is how we did decrease the UTI rates considerably, as well as this is how it was seen in terms of the brief use in surgery. So what now? So the biggest thing and our biggest barrier right now is that we did all of this great work. Our length of stay has dropped as well because our elderly are now more functionally mobile. They are not getting UTIs. Their IADs are practically non-existent. It is that because of the 3 products, they are changing them more frequently as well. The cost overall went up 17% for product, and that is only containment product, okay? Containment and collection product went up. Number one, they weren't using collection products before, so of course it's going to go up. Number two, it is that we are down to 3 products, but also patients are changing themselves so that the product is available more. What is in our briefing note to senior exec is that you have to look at, we decreased the IADs, so the treatment of pressure ulcers and IADs with the number of medications, UTIs have dropped considerably, so look at the cost of a UTI in a hospitalized patient, dropped considerably. So what we've got now is the final data about how much cost saving to the system overall. So what I say to you ultimately is, it's not just about the UTI IAD. We actually made a huge difference in patients' lives, and they went home with a better idea, certainly, about how they themselves could remain continent. So I leave you with that, and if there are any questions, and we are more than willing to share our continence protocol and any of our learning with you. Yes, 2 weeks prior. So the PSQ, which is the pre-screen questionnaire, all patients coming in to hospital 19 years or older in Fraser Health are, and if they're admitted, they're all given the pre-screen, and in that it says 2 weeks prior to your hospitalization, what was your status of? And the questions. It's factored into the care plan. If the patient answered yes, they were incontinent prior to, or no, there was not a problem with their bowels and their bladder prior to, like 2 weeks prior to getting sick and coming into hospital, then yeah. But if we ended up seeing that there was a problem within the first 48 hours after hospitalization, then everything kicked in. Okay, and there were really, like the algorithms were really helping them guide their care and their care planning. Yes? So until the final executive says go, however, in saying this, I know that it's already started in 3 other hospitals, and our biggest delay is always getting the supply chain to change from the storehouse and the automatic top-up on the units. It can take months to get the change done, and that's been our biggest delay. The staff is wanting to do it, the staff is ready to do it, because they're looking at their data that's being reported out for UTIs, for example, and pressure ulcers, and they're saying, we're doing everything. What else can we do? So they're ready. That's the whole issue, is that when the staff says they're ready to change, that's when we need to change. Thanks ever so much, and I hope you have success